Hello everyone. We will discuss radiographic approach to bone tumors. It is important because it is frequently asked long case in final radiology exam and also for day-to-day practice as a radiologist, and even for orthopedicians it is important to detect the lesion on radiograph to characterize it and to give differential diagnosis. The first part we will cover the pathological types, then what are the 10 criteria based on which we will approach the bone tumor. We will see one by one. Individual benign and malignant tumors we will cover in the second or third. Pathological classification and approach to bone tumors we will cover in this. This is a pathological classification of primary bone tumors. Primary. You remember that secondary bone tumor is the most common lesion, even if it is solitary in adult patient. This slide is covering the primary bone tumors. In that we have divided it into the benign and malignant, and also based on which histopathology, that cartilage bone forming giant cell tumor. In cartilage forming benign we have chondroma, osteochondroma, chondroblastoma, chondromyxoid fibroma. In malignant we have chondrosarcoma, mesenchymal chondrosarcoma and clear cell chondrosarcoma. In bone forming in benign category we have osteoma and osteoid osteoma and osteoblastoma. In malignant we have osteosarcoma. GCT, giant cell tumor, can be both benign or locally aggressive. In marrow tumors we have lymphoma, leukemia, multiple myeloma, and round cell tumor we have Ewing sarcoma, pinnate, primitive neuroectodermal tumor. In vascular hemangioma, lymphangioma, vanishing bone disease, cystic angiomatosis. Connective tissue disorder in benign category we have non-ossifying fibroma, benign fibrous histiocytoma, lipoma, desmoplastic fibroma. In malignant we have malignant fibrous histiocytoma or fibrosarcoma, miscellaneous neurofibroma common in jawbone, then chordoma in malignant type. Tumor-like lesions we have bone cyst, aneurysmal bone cyst. In Langerhans cell histiocytosis we have eosinophilic granuloma, most common. Then fibrous dysplasia, implantation epidermoid, brown tumor, osteofibrous dysplasia. Okay, then what are the imaging modalities available? We have radiograph for the lesion detection and characterization. CT is used for the complex anatomies like pelvis and skull, and MRI is used for the staging, which parts are involved, adjacent to which muscles, nerves, or whether joint is involved or not. Then bone scintigraphy is used for the metastasis detection. Then these are the 10 important criteria based on which we characterize the lesion: age of the patient, then which bones are involved, then what part of the bone is involved, like whether it is involving the epiphysis, metaphysis, or the diaphysis, and whether the lesion is cortical based, medullary, or periosteal. Then the margination, whether it is narrow zone of transition or wide zone of transition, means whether it is well defined or ill defined. Then whether the cortex is thickened or thinned out or restricted. Then the behavior of the lesion, whether it is lytic, blastic, or mixed. Then matrix, based on the radiograph findings we can predict the extracellular substance of the tumor. Then ninth is the periosteal reaction types, and last is the soft tissue changes. We will see one by one in detail. Then age, based on the age we have above 30, below 30 we can remember. Epiphyseal growth plate also fuses at this age in most of the bones. In adult patient, these are the red ones are the malignant ones. We must remember that metastasis is the most common in the adult patient, then myeloma, then chondrosarcoma, parosteal sarcoma, fibrosarcoma, and chordoma. Then osteoma is a benign type in adult patient. Then in the below 30 or in pediatric and adolescent patients we have simple bone cyst. Then in benign type, in then chondroblastoma, non-ossifying fibroma, osteochondroma, fibrous dysplasia, osteoid osteoma, then aneurysmal bone cyst, eosinophilic granuloma. In malignant type we have in pediatric, early pediatric age group, Ewing sarcoma. In the latter adolescent age group we have osteosarcoma. Then these two tumors overlap the age group. These are the GCT, giant cell tumor, and enchondroma. Okay, enchondroma is a benign type. Then according to the bone tumor, this is the age group which is there common. It is given metastasis, as we know, it is more in the adult patient. Then it is a primary malignant, primary benign type. It is in the table format. Then we will see which part of the bone is involved, whether it is involved in the cortex or the medulla, and also we will see which position, means whether it is epiphyseal, metaphyseal or diaphyseal. First we will see above 30 age group. In that, first we will see the epiphyseal part. In that we have giant cell tumor, osteomyelitis also kept in this because it acts as a DD, not a tumor obviously, but it will mimic the lesion. Then the geode, it is again not a lesion, it is a large cystic subchondral cyst in osteoarthritis, degenerative changes. Then coming to the metaphyseal and central, we have enchondroma, and the malignant counterpart of it is chondrosarcoma. And more towards the diaphyseal and central will be the metastasis and multiple myeloma. Then coming to the early age group, means below 30, and in that we can see this is the epiphyseal growth plot which is not fused. In that epiphyseal are the chondroblastoma and osteomyelitis. Okay, and we will first see the cortical lesions. In that we have osteoid osteoma, this is the central nidus, and peripheral sclerosis. Then we have non-ossifying fibroma and fibrous cortical defect. Then this is the bony outgrowth osteochondroma. So these are the cortical based osteoid osteoma, then the non-ossifying fibroma and osteochondroma. Then coming to the central lesions, we have enchondroma. It will be more metaphyseal. All these lesions can be metadiaphyseal, but these will be more metaphyseal and then extending into the diaphysis, and these will be more diaphyseal and then extending into the metaphysis. So these are the central lesions. In that we have enchondroma, then the simple bone cyst, then the fibrous dysplasia, and here we have eosinophilic granuloma, then the Ewing sarcoma and the round cell tumor like Ewing sarcoma type and pinnate, primitive neuroectodermal tumor. Then uh, this is the osteosarcoma, the most common pediatric bone tumor. It will be metadiaphyseal. It will be relatively eccentric. It will show cortical break, periosteal reaction. It will be more metaphyseal than the Ewing sarcoma, which will be more diaphyseal. Then these two, chondromyxoid fibroma and aneurysmal bone cyst, they are medullary lesions, but they will be relatively peripherally placed. Okay. Okay. Then coming to the margination, we have, this is the lesion. It is showing a sharp margin. In other words, it is showing the narrow zone of transition. This is the osteolytic lesion. We can see this tiny lucencies, but it has a wide zone of transition, means doesn't have any sharp margin. We cannot tell exactly where the normal bone starts and where the abnormal bone ends. Okay, then behavior, we have three behavior: osteolytic, osteoblastic and mixed. In the osteolytic we have three: geographic, moth-eaten and permeative. This is geographic. It is a well defined lytic lesion. Okay, then it is a moth-eaten. In that lytic variety we have these lucencies. Can you see these lucencies? This is the These are the lucencies, and it is a moth-eaten type of destruction. Then if the lucencies are very tiny like this, then it is a permeative type of bony destruction. Okay, in this image we can also see it is showing a wide zone of transition and also periosteal reaction. This is the periosteal reaction, we will see it in detail, and also it is showing a soft tissue mass. Here again it is showing a periosteal reaction, soft tissue mass. Okay, we will see the periosteal reaction detail. So here we have covered the osteolytic type, in that three types: geographical, moth-eaten and permeative. Then the osteoblastic, it will be, this is the osteoblastic lesion, and mixed, this is the lysis and blastic in a same lesion, so it is a mixed type. Then we can predict the matrix on the radiograph. First matrix, that is the extracellular substance, is the fat. The typical location of lipoma is calcaneum. It is showing the lucency and central calcification. Then second most important is the cartilage extracellular matrix. In that it is showing, you can see the tiny discrete opacities. This is a stippled type of calcification. This is the relatively larger discrete opacities. It is a flocculent type of calcification, and here it is a ring, and here it is a arc. This is a ring and arc type of calcifications which predict the extracellular matrix as a cartilaginous type. Then osteoid matrix will be the like ivory type. Then the fibrous matrix will be like smoky ground glass type. Okay, then the periosteal reaction, this is a solid, it will be more towards the benign, and then the lamellated alternating periosteal reaction and the lucency band will be there, and the speculated means perpendicular, and sunburst is the same, perpendicular, but it will be focal, means it will be like rising from a single focus and giving the sun rays like type pattern. So then this is the Codman triangle. Here we can see the Codman triangle better. You can see the cortex is distracted, and periosteum is elevated, and what is there, there is a new bone formation beneath the elevated periosteum and the cortex. So this is the new bone formation which is called a Codman's triangle. So it is at the most aggressive spectrum of the periosteal reaction. Just 2 minutes on this lesion. This is a bone in which there is epiphyseal growth plate is not fused, and this is a metaphyseal lesion, metadiaphyseal lesion, eccentrical placed cortex is break, and it is lytic, and it is showing a permeative type of lytic destruction with a wide zone of transition, and also it is showing a soft tissue mass here and Codman's triangle here. Okay, then this is a solid type of periosteal reaction. This is a lamellated type alternating dense periosteal reaction with intervening lucencies. Then this is a perpendicular periosteal reaction. Can you see the perpendicular periosteal reaction? And this is the again a pediatric patient with non-fusion of the epiphyseal growth plate, and this is the blastic type of lesion, and it is showing osteoid matrix because it is a ivory type. Okay, so we saw the histological types of the bone tumors. Then we saw the approach by using the 10 criteria. In the next, we will see individual bone tumors. Thank you very much. Thank you very much.